Welcome, friends. It is our great pleasure to introduce you to SICOT Pioneer. Pioneer is a program of innovative orthopedic networking, e-learning, education, and research that was designed to fill the gap left by the absence of face-to-face meetings, courses, and other activities during the 2020 coronavirus pandemic. But Pioneer has become so much more than this in the intervening year. Pioneer is a virtual, but also very real community of like-minded orthopedists striving to help not only themselves, but one another. With the latest video conferencing and educational technology, as well as a groundbreaking online platform, SICOT's Pioneer events, activities, and resources are reaching every corner of the globe, with over 55,000 views of our webinars so far. We're forging new partnerships, signing agreements with 12 other international academic societies, and building an enduring network we hope will last for many years to come. So, what can you expect from us? Free webinars led by key opinion leaders from around the world and across all fields of orthopedic surgery and traumatology, as well as chat shows with some of the most interesting and inspiring surgeons on the planet. Opportunities to take an interactive role in these webinars by participating in polls and live discussions. Free on-demand Pioneer playback service. Watch our webinars again and again in your own time. And coming soon, our new bespoke learning management system will host podcasts, an online version of the famous SICOT diploma exam, virtual training modules, surgical technique courses, a discussion forum, and much, much more. We hope you'll join us on this pioneering journey as we push the boundaries of what is possible in online orthopedic education together.
Hello. Hello. Good afternoon from Bittamor, Nepal. And let me welcome all of you to this SICOT session during this Nepal Orthopaedic Association annual conference at Bittamor. I'm extremely thankful to SICOT as well as Nepal Orthopaedic Association for providing us this opportunity to have this collaboration during our meeting. So we will, with us, have our president of SICOT, Dr. Vikas Khanduja, then our Asian representative, Professor Inho, then Academy Chair, Margaret, all of you most welcome. And then I think Sureshan, is he online or we are waiting for him? So he is also there online. So I think without wasting any further time, I think I will hand it over to Vikas for his talk. Thank you.
Thank you very much indeed for the kind introduction, and it's an absolute pleasure and honor to be there with all of you. Thank you to the Nepalese Orthopaedic Association for hosting us, and to Margaret and the whole team for organizing this fantastic webinar, which is actually being live streamed to all around the world as well. So I'll just start off with what exactly is SICOT and what can you potentially gain from it, being a trainee, being a surgeon in Nepal. So if you look at it in terms of the orthopedic organizations around the world, it is the oldest international orthopedic society, established in 1929. And we are coming up to our centenary year soon. And all the big names in orthopedics that you can think of are actually out there forming that organization. We've got a fairly well-established organogram in terms of the way the organization runs. So we've got two arms which actually make sure that the organization runs effectively. That is the governance arm and the financial arm. And Sureshan, treasurer actually leads the financial council. And then we've got two effector arms, that is the Research Academy and the Education Academy. So all the things that happen in research and education actually happen on those two academies. And you can see that there's a fairly good spread from people around the world who are actually leading these committees and academies. Now, we realize that the whole world is actually moving towards subspecialty education and subspecialization, and that for us is extremely important. And our boss, or the board of orthopedic subspecialties, is actually led by Hatem Said, who is our president elect. And you can see that we've got 15 subspecialties, right from computers and enabling technologies to tumors. And we've got people from all around the world again leading those. So if you are a knee surgeon and interested in a knee as a subspecialty or hip as a subspecialty, then you've got the opportunity to join these subspecialties via SICOT Connect when you renew your membership. And through that, we can actually, you can see that we are doing orthopedic world congresses. Our scientific program essentially is a congress within a congress, wherein we've got pretty much these 15 subspecialties embedded in the congress. So if you're a knee surgeon, you can just be in the knee room for almost 3 days and learn everything that you need to know about the knee. We've got a well-established SICOT diploma exam, which is pretty much like the FRCS Auth in the UK or the FRACS with MCQs and the Vivas. We've got heavily discounted fees for low-income countries, free access to orthopedic evidence and clinical orthopedics and related research, and we've got two of our own journals, which is SICOT-J and International Orthopedics. SICOT Pioneer, you've already heard about. Through that, we do events like this, webinars every 2 to 3 weeks. We've got all this happening through the academies and councils. And most importantly, if you're a young surgeon or even a mid-career grade surgeon, and if you wanted to travel the world on fellowships, then we've got 40 fully paid fellowships and lots of awards in the congresses for you to access. We've invested heavily in digital education, and that's the SICOT Pioneer Digital Education Platform. Through that, we do webinars like this. But more importantly, we've recently come up with the concept of something called virtual training or certification modules. So we've launched it in ACL reconstruction. So if you wanted to be certified in ACL reconstruction, there's a 4-month program that you actually go through and you can be certified in ACL reconstruction. We are soon launching the pelvic and acetabular trauma module or certification course, which is delivered by faculty from all around the world. So do look out for these certification modules if you are interested in something specific, which is delivered virtually. Diploma exam now you can do actually from the comfort of your own home. We've made it completely virtual, both the MCQ and the Viva. And we've also recently come up with the concept of virtual fellowships. So somebody in Nepal could be doing a fellowship virtually with somebody in the US or the UK over a 6-week period through the virtual platform. And we've piloted that, and that's gone extremely well. On the face-to-face education academy side of things, we've got the Young Surgeons Council, which again, we are hosting the first Young Surgeons Council for this year, their academy meeting, along with the ARCUS meeting in Chicago in month of May. So if you're interested, that would be a good one to attend. We've got lots of Congress awards. We've got the Congress Scientific Program for you to be a part of. The fellowships, as I've already said. And recently, we've launched something called the Spectre program, which is a crash course for the exam. And finally, you've got cadaver courses happening in Singapore if you're interested in the arthroscopic side of things. So there's a lot happening, again, for the young surgeons and the mid-career grade surgeons. So research is important for both advancement in your career and also for patient benefit. We give research grants, 10,000 for pilot projects, up to 3 grants. We've got lots of research awards. We also do a fair bit of research education in terms of the Pioneer webinars and the GCP course. And we'll be doing something similar in Kyoto with our Congress. If you're interested in taking part in our clinical trials, then we've recently launched the Global Clinical Trials Network. Over 130 PIs have been registered for that. And we've got a new task force for AI and machine learning and regenerative medicine as well within the SICOT Research and Innovation Academy. The diploma exam, as I said, we do it completely virtually 8 times a year, and you could be taking this exam, both the MCQ and the Viva, through that. And you can see all these benefits, and these are over 60 of them, actually come to you for a fairly minimal amount of price. For the trainee, it's only 100 euros. And for a practicing surgeon, it's 200 euros. Emeritus members are free. So that's in a nutshell all about SICOT. It's a great organization to be a part of. It's vibrant, it's growing. We've recently had over 30,000 corresponding members coming from various countries. Italy, Japan have signed up. South America countries are thinking like Argentina and Brazil to come on as corresponding members. Sudan recently is thinking of coming on as corresponding member as well, along with Sri Lanka. So a lot happening, a vibrant community, and we would love Nepal to be a part of this. So that's in a nutshell all about SICOT, and I'm going to stop there. Happy to take any questions whilst I load my academic talk for this event.
Hello, Vikas, can you hear me?
Yes, loud and clear.
Yeah. The question which has come from the younger group is regarding the fellowship, how they can get those fellowships opportunities.
Yeah, that's a very good question. So there is a whole fellowship committee, and if you are a member of SICOT, you can log on to our website, and all the fellowships that are available are out there. So there are quite a few named fellowships as well, and they have been categorized both in the type of fellowship in terms of long term or short term. They've been categorized based on the subspecialty that you want to do. And the other good thing that we have is also called SICOT meets SICOT, which means that a junior SICOT trainee can go and meet a senior SICOT trainee or senior SICOT consultant anywhere in the world for up to 4 weeks, fully paid for by SICOT. So if you wanted to do a targeted short-term fellowship, then those fellowships are actually good for you as well. SICOT meets SICOT. And then there are long-term fellowships, for example, in India, in ASUIT, in USA, which actually SICOT funds completely. Now, obviously, they are competitive. You need to apply with your CV, but a lot of people have actually gained a lot of training through these fellowships. So everything is there on our website, all these 40 fellowships, and the SICOT meets SICOT as well, which you can access from there. But these are only for full members, not for corresponding members. So even if you're a trainee and you're an associate member, then you can access those fellowships.
Mm-hmm. Oh, that's nice. And what about the young surgeon member? Do they have a different membership, or they are from the one SICOT membership only?
No, so the young surgeons have got pretty much, we do half the rate for them. Associate members, these are the members under 40 for the young surgeons. It's half the membership rate as for any other surgeon. And then they've also got the opportunity to join the Young Surgeons Committee. We've got a program called the SICOT 360. And in fact, after this meeting, if you can send us the names of 5 young surgeons, then we would incorporate them into the SICOT 360. And these would be the future leaders of SICOT will essentially come from the SICOT 360 program.
Okay. Thank you, Vikas, for your very detailed explanation about SICOT. This helps me also a lot, because now lots of people are getting interested, and we are looking forward to the Kyoto meeting in Japan. So thank you.
Thank you for this opportunity. And as I said, we would love to collaborate a lot more with Nepal. And perhaps corresponding membership with the Nepalese Orthopaedic Association may be a good way to actually start this collaboration.
Sure, I'll talk with these executive committee, and we'll let you know very soon about how best we can do, and this strengthen our collaboration further in the future. Thank you. Thank you.
Thank you. Okay, and now let's come to the academic part. So this concept of doing this webinar was about innovation and technology. And what I wanted to share with you is the lessons that I've learned over the last 8 years in trying to develop something in the hip joint, and the mistakes that I've made, and hopefully those mistakes you don't make. And most importantly, the whole point here is that if you've got an idea, how do you actually take it forward to innovation and actually creating something? So I bring you greetings from a biomedical campus in Cambridge, and we'd be delighted to host you if you ever wanted to visit us. I run the Cambridge Hip Preservation Service with two other colleagues of mine, Mr. Sunil Kumar and Professor McCaskey, and we serve the population of East of England for young adults with hip pathology, also parts of Ireland, and that's supported by physios and fellows of pretty much from all around the world. We've got a well-established research group with 6 PhDs, MDs, and MPhils, and some of the work that you see here is thanks to them. These are my disclosures, and a couple of them are actually relevant to this talk. So if we look at hip pathology, that's what we deal with. We could probably categorize the patients who come to us into 3 major groups. So we've got young adults who've got the diagnosis of FAI, dysplasia, avascular necrosis, where their articular cartilage is well preserved, and we can think of hip preservation surgery for them. In the last group, we've got the young adults with FAI, dysplasia, osteoarthritis, rheumatoid arthritis, but their articular cartilage degradation is quite severe, and they've got severe arthritis, and they actually are for hip arthroplasty. So those two are fairly straightforward. A large chunk of these patients are actually in the middle, where they've got all these diagnoses, but they're beginning to get some degree of articular cartilage damage, and there is the treatment gap group. So these are the 3 sort of patients that we are seeing on a regular basis. The second stat to keep in mind is that if you look at osteoarthritis in the hip, it is rising significantly, but also the demographic is shifting to the younger adult. And if you want to put numbers onto it, then we perform almost 100,000 primary total hip replacements in England and Wales. There's a 134% rise from 2012 predicted to 2030. If you look at the US, it's more than 635, 100,000 hip replacements by 2030 that is predicted. Specifically, within our National Joint Registry, patients under the age of 60, about 20% of them are actually having their joints replaced. And about 42% of them are going to fail at 25 years. And also with hip replacements, we think it's only with knee replacement, but even with hip replacements, there is a dissatisfaction rate of almost about 8 to 11%. Now, Charnley said, even as early as in the 70s, that the challenge would come when the patients between the ages of 40 to 45 years of age are to be considered for an operation, because then every advance in technical detail must be used if there were to be a reasonable chance of 20 or more free years of trouble-free activity. So even then they realize that operating and doing a hip replacement on a young adult is going to be tricky, and it has to be a perfect joint replacement. And that's what we are facing now. A lot of the younger population is actually having their joints replaced. And when younger patients have their joints replaced, the issue is that they have increased amount of forces on the joint for longer. So if your joint has to survive 25 years, there's the obesity epidemic. You want to do a lot more with your joint, play tennis, play football, whatever, and you're surviving long. That means that joint has to survive those forces for an increased period of time, and those forces are only increasing because of the obesity and what you do with it. The other issue is that whenever we talk about joint replacements, we only classify the success or failure of joint replacements as revision surgery. So as long as the joint is not revised, you think that the joint is done well and it is a success. But what we do not pay attention to in most systems is those patients who've got a joint replacement, but they're still in pain. They are still not functioning to their optimal level. So actually the continual pain loss of functionality is not talked about even in papers. Some papers talk about dissatisfaction, but actually, if you look at it, those are young patients, and a lot of them may not be able to get back to what they were doing prior to that intervention. And I clearly remember this fireman, 42-year-old. I replaced their hip. X-ray wise looks pretty good, but he continued to be in pain. We've investigated him thoroughly. We can't find anything, but lateral pain continues and he's struggling. He had to give up his job. So the impact on his life, job, economic impact on the country, and the risk of revision as well is there. And these are actually the problems that you see or that I see in my clinic, a lot of them. These are the dissatisfactions, or actually I start calling them partial failures now. The unexplained pain, the leg length inequalities, the prosthetic impingement, offset mismatch, functional limitation of soft tissue problems are actually very high in these young adults. So the first lesson that I can tell you that I've learned in this is that true problems are staring at you in the clinic. So if you want to make a contribution to science, if you want to change something, if you want to innovate, you don't need to go and search for problems elsewhere. If you do a busy clinic, you will actually start finding patterns in your own area, in your own country, which questions actually need answering. So all these problems and the questions that really matter are actually staring at you in your outpatient clinic. That's the first lesson. So obviously that was the question that I wanted to answer. One of my fellows from Japan, Junya Yoshitani, was with me at the time, and the first question we wanted to answer is whether the patients under the age of 55 are less satisfied than those over the age of 55. And second thing we wanted to determine is that if the patients who had minimal arthritis on the X-ray, were their outcomes similar to those patients who had severe arthritis on the X-ray? So I'm not going to bore you with the details of how we did it, but essentially a systematic review looking at over 1,700 hips. And this is clearly telling you that the patients under the age of 55 years old had a satisfaction of 90%, whereas over the age of 55 had a satisfaction of 96%. So basically, there is a difference in satisfaction and the level of expectation in young patients having joint replacement. Secondly, what about the severity of preoperative radiographic arthritis? Clearly, again, another systematic review looking at over 8,000 patients. And what this tells you is that patients who had joint replacement early with mild radiographic arthritis are less satisfied and their scores are less than those who had severe arthritis. So that clearly tells you that the younger patients and the patients with less arthritis are the ones who are actually struggling. And why is that? Obviously, probably because of expectations. The younger patients expect a lot more. Their perception of pain may be different. Their activity levels are definitely different. Difference in pathology. And perhaps it is grit. The older generation had grit and the younger generation probably doesn't. Or is it something that we are not picking up during the surgical intervention? Now, the whole world is actually focused on alignment. If you look at the push in technology, everybody is talking about robots, the Naviswitch, smart assisted surgery, and they're telling you where to put in the implant precisely. But what nobody is talking about and what is missed out is the soft tissues, whether it's the knee, whether it's the shoulder, whether it's the hip or the ankle. Every joint has got a huge amount of soft tissues around it. But nobody talks about, or we seldom talk about soft tissue balance in this, and we just focused on alignment. If you look at the hip replacement or even the knee replacement, our implant positioning and balance would depend on the surgeon's hands and skill, but not objective assessment. There's no real-time feedback of forces to guide implant placement or tensioning. And these unbalanced forces can actually lead to these problems and the so-called dissatisfaction. So we do the shuck test or the drop kick test in the operating theater whilst we're doing a hip replacement. And that's just based on feel, but there's no objective way of actually finding out whether the soft tissues are balanced or not. So that's the second lesson in science or in innovation. That is, if you cannot measure it, if you're not recording it and not measuring it, you cannot improve it. So if you really want to improve something, first, the least you need to do is actually start measuring that. And only then will you know what exactly is happening. So another fellow of mine from Israel, I put a question to him that this is what we want to do. We want to measure the forces going through the hip joint to balance the hip when we're doing a total hip arthroplasty. So he, like a good fellow, went and started dissecting this problem and then came up with the idea that I've got a good friend of mine who's from Israel as well, who's an engineer. Let's go and chat with him. So we go and chat with him, and he's actually working in the lab of this lady who is an engineering professor, Shoni Kanarayan. And that Israeli makes us meet another Israeli, makes us meet this Indian. And what we realize is that we were studying probably about 100 kilometers apart, our undergraduation, and we land up meeting serendipitously in Cambridge to actually discuss this problem. So that's the next lesson, that if something is happening to you, absolutely through serendipity, please believe in that, because you do not know where it's going to take you. Because if you believe in the serendipity process and if you have a prepared mind with an unexpected event, you need to make sure that you recognize the potential of that event, seize the moment, and then you start amplifying the effects. So whatever is happening for good. So maximize serendipity and give in. So we started talking, and our solution, thanks to Shoni and her team, was we need to get sensors to guide positioning and tensioning in the joint. The hip is a fairly tight joint, so she came up with the concept of microfluidics conformable sensors, which are as thin and as small as you can see, a 20p coin, and they're based on the simple process or simple physics process of actually getting those sensors through fluid and measuring the forces through the joint. And that's what we did. So here you can see we are implanting these sensors, the thought process, into the acetabular liner so that we can actually start measuring the forces going through the joint whilst you're doing the hip replacement. So based on this, we started conducting experiments within the lab, started publishing papers on this, and did the initial clinical trials on the cadaver as well. So these you can see are 3D printed ones. We've created channels for the sensors to go in. We started off with these sensors attached with wires going on, and then able to actually see what was happening in terms of force sensing. A fair bit of lab testing to make sure that what we were actually perceiving was being delivered in the lab, and we were able to see the changes. So you can see here in the lab itself, on this video, the changes, for some reason that's not displaying, but essentially the changes for up to 700 Newton can be seen through this. Then we took it to the lab. So the hip is in neutral at the moment. And made sure that we were able to replicate this, what we do in the operating theater, and see the changes on the screen as we are actually taking the hip through a range of movement to see for impingement and dislocation. But clearly you can see that these are wires attached to the sensors. So we clearly had to evolve because we can't be having 6 wires coming out. So that's what we started off with wires. Then we went on to the wired with the Bluetooth one. And finally, the current iteration of the sensor is this, with a battery, no wires, fully inside, lots of sensors actually getting the data, and pretty much like a trial liner, 3D molded through the battery and the sensors, giving you the full data on the screen. So that's the current evolution of the sensor. And then the company ArtioSense was born. And this will tell you what exactly it's doing now. So this is the microfluidic force sensing technology. For precision force balancing, we've started with the hip, but we will go to all the joints, the knee, ankle, anything that's being replaced, which is going to give you real-time force measurement whilst you're doing the joint replacement to make sure that the joints that you're putting in are perfectly put in with soft tissue balancing. So you put it in the liner, start assessing your joint. Once you've assessed your joint completely, you move the joint and you will get your force positions based on level of impingement or dislocation, and you can get your offset as well. Once everything is clear and all those are green, you can exchange that, mark the position of your components, take it off, and replace it with your final implants. So it doesn't change the workflow of the operation, doesn't change what you're doing. It's only that the trial lineup becomes extremely smart and gives you a fair bit of data going through. So this company was set up then, and we clearly realized that an engineer and a surgeon can't just carry it through, and then people start coming on board. So we got Paul White, who's a clinical engineering lead. We've got Jangir Kamana, who's a biophysics and microfluidics expert. We've got Amanda Stranks, who's the PPI lead, and Alex Shimoshkin, who's the translational officer lead. And once you've got a team, then actually things start happening. So that's the next lesson. You can't do it alone, and you really need a good team to make things happen. And once the team came in, then all these things started happening in terms of what is the market analysis. We start getting numbers on that. What is your competitor analysis? Who else is actually in the field? And then you're talking about clear product development of a medical device and taking it to the market. So you're thinking about a regulatory pathway, both in the US, Europe, and Far East as well, and the patient public involvement. And all these things can happen only because of a good team. And then lots of publications, invitation to the parliament to talk about our invention and innovation and pushing forward, and then awards and grants coming in as well. So what I'm trying to highlight here is that you really need a good team to push things forward. You can't do it alone, and you really need smart people from different fields to come together to push one innovation forward. So the mantra really is that you need to think of collaborating with others all the time, but you need to compete with yourself and be the better version of yourself every day. And you really can't be doing these things alone. Collaboration definitely is the new competition. And that's what you need to be thinking of. And then from 2018, 2019, when we thought of the idea, to 2023, the first prototype of the wireless was developed, and that was through 14 translational grants of up to $500,000. Then we got a large grant with the NIHR from quarter four of 2024 to 27, 29, we'd be ready for clinical trials and commercial partnership development. So we've got about 1.4 million from the NIHR now to get to the cadaveric trials and the first in human, and then we'd be getting into the market by 28, 29. So that's sort of the life cycle of a product. The other lesson that I would want to leave you all with is, what do you think is common in all these companies, be it Amazon, Facebook, Google, or Apple? And if you boil down all these companies to a single thing comes out, and that is data. all these companies are actually based on data. So if you want to really innovate and if you want to contribute, data is the new oil, and you really need to be thinking of how are you going to capture data. For Nepal, the biggest thing is that you've got population, you've got unique problems. How do you capture that data, which is going to be very unique to Nepal itself, and that becomes fairly relevant then. And then our long-term ambition is leaving these sensors behind to get the data for specific hips, and also thinking of obviously implanted sensors with antibiotics as well to reduce the risk of infection. They can also be a huge help, and we've checked that in the lab in terms of training. So actually robotic surgery is out there, so we could be implanting sensors into the gloves and the robots for sensing and seeing exactly how we can help with training in this arena. Now, I don't know where this is going. I don't know whether this is going to be used with every hip replacement and every knee replacement tomorrow, but obviously that's our ambition. But I wouldn't want to focus on that. I would want what I've had over the last 8 years is a fantastic journey. And this is the last lesson that I want to leave you with, that enjoy the process and enjoy the journey, and don't worry too much about the end result, because we'll definitely, all of us will have a parking spot in the end somewhere. So the takeaways from this journey are that the first is true problems are actually sitting with you in the clinic and staring at you, and that needs solving. So when you do your next clinic or when you're doing your next operating list, please just look at what is the common problem that you're seeing and have an innovative mind and try to solve that. Second issue or second lesson is that you really need to believe in serendipity and just surrender. And if you do surrender and really believe in it, it will take you places. If you can't measure it, you can't improve it. Certainly start measuring whatever you're doing. You need to collaborate with others and compete with yourself. Data is definitely the new oil. Without data and without measuring, it'll be very difficult to actually improve anything. And the final bit is you need to enjoy the process and the journey. Don't worry too much about the end result. And on that note, I would like to invite all of you to Kyoto, where the next SICOT Congress is, where it is the bridge from history to innovation. And we would love to have a lot of abstracts coming from Nepal to the Kyoto meeting. Love to see all of you from Nepal in large numbers out there. A scientific program being prepared by Alaric Arugis. We had a fantastic meeting in Madrid, and we would want to better that and make it the largest meeting in that part of the world, with over 1,500 international delegates expected as well for that meeting. And on that note, thank you very much. If you wanted to reach out to me, those are my social media handles. I know the young generation likes that, so DM me and would be more than happy to answer. And I'll stop there. Thank you very much for hosting us.
Thank you,
Vikas,
for the invitation. Obviously, yes, there are already a number of abstracts submitted, and we all are looking forward to the Kyoto meeting, because this is in Asia and it's nearer to our place. So we hope that we will have a big number of people visiting. I think you saw there were so many of us there in APO meeting, so why not SICOT? So we will be there. Thank you.
Thank you very much indeed. Thank you.
Thank you.
Thank you.
So now can we move on to the next talk that is by Inho? I think he is flying, so we will have his talk on the digital revolution in orthopedics. So over to you, Inho, please.
Good afternoon, respected colleagues and dear friends in Nepal. It is a true privilege to be with you today. Whenever surgeons gather together, regardless of geography, we are all united by a single purpose: to improve the lives of patients who trust us with their care. And today, we meet at a remarkable moment in the history of medicine, because we are not simply witnessing technical progress, we are witnessing a transformation in how medicine is practiced, how decisions are made, and how outcomes are shaped. Digital medicine is no longer a distant vision. It is the present, and it is advancing faster than many of us anticipated. So the question before us is not whether this transformation will happen, it is already happening. The real question is who will lead it? Will surgeons step forward to guide this change, or we will allow others to define the future of our profession? History has shown us something very clearly. Technology alone never transforms medicine. Leadership does. Digital transformation is not an IT project. It is professional responsibility. For decades, orthopedic was a craft refined through experience and judgment. Then came evidence-based medicine, bringing consistency and scientific rigor. Now we are entering a third era, intelligence-augmented surgery. An era where data supports judgment, where prediction complements experience, and where technology strengthens rather than replace the human touch. Medicine is moving from reaction to prediction, and this may be the most important shift of our generation. Technology is accelerating, data is expanding, patients' expectations are rising. But the future will not be decided by technology alone. It will be decided by those willing to lead it. This moment is therefore not only about innovation, it is about stewardship. It is about protecting the integrity of our profession and above all, protecting our patient. Because clinical wisdom must always remain at the center of healthcare innovation. Allow me to briefly share a perspective from Asan Medical Center, where I had the privilege of helping lead digital transformation initiative. For us, digital transformation is not the theoretical, it is operational. Does this make care safer? Because technology that does not improve safety is simply complexity. Through global, connected, virtual collaborative platform, our physicians discuss cases with experts across the borders. Knowledge is no longer confined by geography. The hospital is becoming borderless now. And where knowledge moves faster, patients benefit sooner. Patient's safety begins long before the first incision. Today, simulation-based training allows the surgical team to rehearse complex procedures and crisis scenarios before they occur. Preparation reduces hesitation, it reduces error, it builds confidence, and confidence protects our patients. We are also witnessing the rise of real-time clinical intelligence, where patients' data is continuously integrated and analyzed, allowing care team to intervene earlier than ever before. Digital transformation, at its core, is not about the machine, it's about better decision. And better decision saves life. Nowhere is this transformation more visible than in the operating room. Information that was once fragmented is now unified. Imaging, patient's history, and surgical image integrated into a single environment. This allows the surgeon to focus less on managing information and more on caring for the patient. The operating room, once considered an isolated space, is becoming digitally connected. Innovation should never isolate us. It should connect us. Perhaps the most profound frontier is the emergence of modeling and simulation, often described as digital twin. For the first time, we can anticipate risk, evaluate implant behavior, and better understand long-term biomechanical outcome. Instead of asking, how do we treat complications? We now begin to ask, how do we prevent them? This is more than efficiency. This is foresight. And foresight is the next frontier of orthopedics. Yet, as we move forward, we must recognize an important responsibility. Digital progress must never widen the gap between the regions. The digital divide must not become the next healthcare divide. Innovation must travel, knowledge must travel, partnership must travel. Every surgeon, regardless of geography, deserves access to education, collaboration, and opportunity. Digital leadership is not reserved for large institutes. It belongs to committed surgeons everywhere. And Nepal is not only the periphery of this transformation, you are part of global conversation. Your leadership matters. This vision aligns closely with the evolution of SICOT. SICOT is one of the oldest orthopedic society in the world, yet history alone does not define the institute. What defines us is our willingness to evolve. Today, SICOT is becoming more connected, more collaborative, and more digitally engaged, an evolution we often describe as SICOT 4.0. Education and global partnership will be the twin engine of our future. Our responsibility is not merely to observe changes, but to guide it responsibly and together. There is a belief that the future will be led by the biggest hospitals. I believe otherwise. The future will be led by the fastest learners, and learning requires curiosity, adaptability, and the courage to evolve. In my journey, I have tried to help bridge clinical excellence with digital capability and to build global partnership that accelerates shared learning, because no hospital, no surgeon, and no nation should walk this journey alone. Colleagues and friends, the future of orthopedic will be shaped not by those who wait, but by those who lead. The future will not wait for us. Let's be the generation that leads it together. Thank you very much.
Thank you, for your enlightening talk on the revolutions, digital revolutions. So now I think we will move on to the next talk, that is innovation in orthopedics by Sureshan. So over to you, Suresh.
Hello, Mr. Chairman, ladies and gentlemen. Thank you for inviting me to give this talk. I'm actually in Singapore, where we just finished the FRCS course, and it's a great pleasure. And I want to thank Ramesh, Dr. Ramesh, for inviting and organizing this topic. I want to talk a little bit about innovation in low middle income countries. Next slide. So low middle income countries, one of the biggest issues is access to resources. And 90% of injury-related deaths occur in low middle income, yet surgical access is most limited there. So the high-cost robotic platforms and proprietary software are often too heavy for these environments. So we have to transition from high cost to low volume and high impact and scalable innovation. Here's a picture from the new National University Hospital Orthopaedic department, and all our colleagues are saying hello. I hope you guys can see my slide. If not, please let me know.
Yeah, we can see you.
Perfect. Okay, so I actually had a good opportunity to talk about this topic to the other examiners, and it's actually fascinating. We believe that this year, 2026, 2027, is going to be a big year for AI, agentic agents, and it can actually transform a lot of the low and middle income countries in a major way. So 1.7 billion people live worldwide with musculoskeletal conditions. So 80% of this burden is from low middle income, but less than 10% of the specialist surgeons work in low middle income countries. I think we're all very familiar with this statistic. Next slide, please. So why are we looking at digital solutions? Because digital solutions are actually very good at leapfrogging legacy solutions to bridge the gap. So you can bridge the infrastructure gap, you can bridge the disease gap, and you can bridge the connectivity gap. Next slide, please. So what are the different apps? I'm sure all of you, even in Nepal, in India, in Malaysia, Singapore, we are all bombarded with a lot of apps, people trying to sell us things, different products. But basically, they can be divided into these different things, like patient-facing apps. For example, we use a home physiotherapy app, machine learning algorithms for fracture detection, remote orthopedic consultations. Now, this is useful in large countries or places with lots of rural health. Looking at 3D printing of prosthetics, looking at digital registries, and also clinical decision support for surgeons. Next slide, please. So what are the current AI capabilities that we have? So there are companies that are looking at fracture detection, bone age estimation, templating, spine deformity measurement, and osteoporosis risk stratification. How it is relevant in our low middle income countries? Most of us rely on X-rays, and the number of misdiagnoses is up to 15% in some studies. AI can maximize the diagnostic yield. How does it help with triage? So AI tools help the nurses and general practitioners to flag urgent orthopedic cases. In areas of low bandwidth, offline capable AI apps can work and help to improve clinical care and triage. And of course, we can use this technology for training and education in resource-limited settings. Next slide, please. So how do we do this? First, we have to pilot, scale, integrate, and sustain. So normally, how we did it in Malaysia is we had to start off with a very simple one, which was home physiotherapy, right? So instead of the patient coming to the hospital every day or every couple of days and getting their physical therapy, they would be seen at home. And what that can do is they can extend one physical therapist to see 3 or 4 patients. So it becomes more efficient. So we first start with a pilot in a single hospital. Then we scaled it for regional rollout. So we own about 13 physiotherapy clinics in around Malaysia. And then you have to integrate into the hospital system. And then you have to sustain it. So that means policy adoption, continuous improvement, and making sure that the stakeholders are super happy. And obviously, one of the biggest things is measuring outcomes. because all this has a cost. And if the outcome is good, the centers are making money, then this is something that will continue to be funded. Next slide, please. So another thing is bridging the digital divide in healthcare. Looking at things like in Malaysia, we have a population of 32 million. The key digitalization initiatives is the National App Platform, digitization of PACS, AI fracture detection, and task shifting protocols. Next slide, please. These are the barriers that we had and how we could overcome these barriers. One of the biggest barriers we had in low middle income countries is with the senior clinicians, we have lack of digital literacy. I think the younger ones are very adaptable, but the more senior clinicians have problems with these systems. How do we act on it? We can actually embed digital training in undergraduate and postgraduate curricula. We can have special training sessions for these senior clinicians who can then learn pretty quickly. In rural areas, we found that sometimes the electricity or the internet is down, and this happens in the rural areas of Malaysia. We have to design it offline first. So a lot of these things can actually be done offline, and there's way to design for low bandwidth applications. So even if the internet goes off, the system is still working. You can input data, you can follow the physical therapy instructions, and you can put all your different notes into the system. The other thing that we faced is sometimes you have high initial technology cost. How did we overcome this? We use more open source platform. We use vibe coding, and a lot of the coding can be done in a very low resource setting. And if you come to the AI session in Kyoto, we will be talking about designing applications for low resource settings. And what used to cost hundreds of thousands of dollars can now be done by AI agents at a fraction of the cost, even a few $100s. Data privacy and governance concerns. The idea is that you must adopt a national PDPA-aligned framework to anonymize the clinical data. And the biggest thing that we have from personal experience is a resistance to the change of the workflow. And this is normal. I think all of the clinicians in the room here, we are aware that change is always resisted, and it has to come with baby steps. So we have to co-design and make the stakeholders and the clinicians feel that they are stakeholders and demonstrate the time-saving early wins. Next slide, please. So how does this digitalization and using of AI agents in low middle income countries help us? It fosters global partnerships. That's the most important thing. We can actually collaborate with many of the global organizations. It invests in local innovation. So in Malaysia, a lot of the younger doctors and engineers are exposed to the innovation ecosystem. And this can actually fund LMIC-led research and development solutions. And this must be designed by and not just for the community. So that means the communities actually designing their own solution. And the next thing, the third thing, is to build an evidence base. And this is important. We have to publish. And the final thing is we have to champion regulatory pathways. So we have to have streamlined, like for example, in our physiotherapy, home physical therapy protocol, we had streamlined pathways that enable rapid and safe development of our healthcare tools. So digital innovation is not a luxury. It's a necessity for equitable orthopedic care worldwide. So if you want to make healthcare the same, for example, in rural Malaysia or rural Nepal, as in the heart of New York City, the only way you can do that is with digital innovation, right? That's the only way, because it can equalize the access. So we have a couple of case studies that I've alluded to earlier in my talk. And these are examples of AI integration in Southeast Asia and Malaysia. And these are like the home physiotherapy protocols, and also the AI, using AI to look at imaging. When tech alone fails, you must have science, which is also backing up the technology. So when you have agentic systems, these agentic systems can actually work to make sure that the science is backing the technology. So our vision 2026 is to empower the next generation of surgeons through digital and AI SICOT initiatives. So I'm actually in charge of digital and AI SICOT initiatives. And we're having a very exciting program in Kyoto where I hope many of you can participate. Next slide, please. So I want to thank you guys for listening to this talk. Here's a slide that we have from our local hospital. On the left is myself with the creators of NOA Robotics, which is a robotics platform, which actually they just started with one robot with one arm 5 years ago. And now they supply all the car companies, BMW, and also Amazon. So a lot of these robots are actually doing a lot of human work. And I think the holy grail is when they combine AI with robotics, right? And I'm sure many of you have read or heard that Elon Musk said, oh, the surgeons can be replaced in 3 years. I don't think that's going to happen, but many of the other things can be replaced. For example, carrying, lifting. And I think once a very affordable robot is coming to the low middle income countries, this will also change the nature of work. As you know, in low middle income countries, cost of labor is less than developed countries, but I still think that eventually quite a significant number of jobs will be done by robotics. I want to thank you for your time and happy to participate in the discussion later. Thank you once again.
Thank you, Suresh, for your excellent talk. And I think we all have to accept that this digital revolution is unnecessary now. We have to adopt to it as early as possible. So once again, thank you very much. And now we will come to the last talk by our academic chair, Margaret, and she will be talking on leadership and mentorship. Thank you. Over to you, Margaret.
Thank you. I'm just trying to get my right. Okay. And thank you. Thank you for the invitation. You can see my slide, can you?
Yes.
Okay. Yeah. Okay. So I'm going to change a little bit of the tone of the whole symposium, because now it's not about the innovations and the digitalization, but mainly about man-to-man, humans and beings interactions. And so I'm going to talk a little bit about leadership and mentorship. So when we talk about leadership, it is the ability to inspire and guide individuals or a team. And in order to become an effective leader, we need empathy, vision, integrity, and adaptability. This is to help to shape the culture and the performance, and to foster a sense of belongings and encourages participation from all team members. How about mentorship? Mentorship is slightly different. It is mainly a relationship where a more experienced individuals leading to a less experienced ones. And it is basically a dual benefit of mentorship, because because the mentors is also able to develop the leadership skills, but the mentees is able to be inspired and have personal and professional growth. So it's a both-way thing. So we do think that the leadership and mentorship empowers individuals to contribute to the team goals, and that is what it needs. And that's why we have SICOT society, where we have the leaders. We're trying to we are talking to different people. We're trying to empower individuals to contribute and then to make the whole orthopedic field. It's not just about SICOT, it's about the orthopedic field and how in the world can improve and can change. So it is encourage a culture of collaborations where everybody's input is valued. And something that is important is about the strength in diversity. So why do we talk about diversity? I mean, it seems as though we're talking about leadership and mentorship, but basically it's because we know that if you look at the studies, we know that organizations with more than 30% of diversity, it can attract the top talent, be more innovative, have make better decisions, and more profitable. And more importantly, in healthcare system, if you have a lack of diversity surgical workforce, you tend to have a persistent healthcare inequality. So what does that mean? So for example, in gender inequity in orthopedics, you noted that there are studies that talk about that if you, in the Canadian Medical Association journal, they said that there's odds of an orthopedic surgeon recommending a total knee arthroplasty to a male patient was 22 times that of a female patient. And the New England Journal of Medicine again said that there's underuse of arthroplasty for severe arthritis in both sexes, but the degree of underuse is more than 3 times as great in women as in men. Obviously, diversity is not just about the race, it's not just about the gender, but also about racial, about ethnicity as well. And there are racial inequity in orthopedics. So you can note that this is done in America, where they have high amputation rate for low limb trauma, poor access to arthroplasty, and poor outcome after arthroplasty in some minority races. And children of a non-English background developed access to orthopedic care in a more of a delayed manner, and Black athletes tend to have a delayed referral for knee reconstructions. So these are all being done. There's a lot of studies going on. And it is noted that in the diversity in the healthcare, that it is noted that diversity improves the performance and outcomes. So there's 16 healthcare industrial studies that have better health and financial outcomes with diverse healthcare teams. So, so to me, how do I? So to tell you about a little bit myself. So I want to be achieved as a good leader and a good mentor. And my challenges to do that is the timing. How do I strike a balance? How do I actually strike a balance between my career, my work life, and my family and my friends? How do I strike a balance? So a little bit about myself and how I can build up and to be in, I wouldn't say a leadership role, but at least in a role in the EC of SICOT, so that I can actually help and be able to offer something to everybody. I'm the 10th female orthopedic surgeons in Hong Kong. So I work in the tertiary university hospital for over 20 years. So now I'm a consultant and deputy chief of service of the Department of Orthopaedics Traumatology, of which I attached to the University of Hong Kong. So there's different roles of me in both local, regional, as well as international. And the ones that you obviously now understand is I'm an Education Academy Chair of SICOT, which means I overlook all the education activities that is being offered from SICOT to any of the members. So the challenges for me is how do I get in, when I should say yes, and now getting more and more important is when and how to say no. When should I actually accept everything, and how should I say yes? That if somebody invited me, how can I say yes? But if there's too many things on the plate, how can I delegate and actually give out to some other people, and at the same time say and find the right person to do it? So there may be certain activities that I would think that I've done it, but then now I should pass it on and get opportunities for other people to have a try. At the same time, I'm moving on to newer challenges. I find that as a minority in the orthopedic field, I was trying to be very much to be an inclusive part of the society. So I feel that it'll be great if they look at me as an all boys, because it's an all boys club. Look at me as another male orthopedic colleagues. But nowadays, actually, what we want to do in order to diversity is not just about that putting yourself in the minority and putting the minority in the whole committee. It's actually integrated, because it is an integration that actually makes the inequity not to have it. So you want to abolish that by actually integrating. You want the minority peoples, you want people to integrate it, to give their opinion and be respected. So this is the integration. It's always nice to have a group of for minority, either is females or a minority group of ethnicity to give support. But at the same time, what we are trying to achieve, and as SICOT we're trying to achieve, is that we want that all of them come together and be a great part of society. So this is the Arthrex hand and wrist course that we've done. And you can see that we have different people from different ethnicity and different generations to come in and help to teach in the course. So this is a picture that I started with as a program chair in SICOT 2022 with Suresh as the Congress president. So I'm the one who designed the program of SICOT. So and so everybody said, "Oh, this is so nice. You can finally see a woman in the whole of the podium instead of all men." I mean, I think SICOT have done really well with because we have reached out to different societies in the world, but then there's some minorities. It is difficult to balance. But what we are now achieving, so that's 2022, and now we're seeing more ethnicity, we're seeing more representative from different countries. We have, and then we have more females. So we have different generation. You can see that it's not just a same age group. There's different age group. That's why we have the Young Surgeons Committee. We have different people, representation from different parts of the world to come in, and we want them to contribute so that we can understand what is needed from all around the world. This is just an example of how integration of what that, because I'm a hand and wrist surgeon. So this is the present council of the Hong Kong Society for Surgery of the Hand. So that's what I'm seeing as integration. We have 50% of them are female and 50% of them are male in the council. And you can see that the other side, on the right side, you can see that these are the organizing committees. And you can see that it is 50%. And it's not because that we want to make it look good. We are actually getting the people who can be doing the best job into the council. And this is just happens to be 50% of female and 50% of the men. So we are hoping that it's not just about gender, as I said, it's about the different ethnicity, different beliefs, different religions that can be done. So how can we achieve that? First, I think as a junior, as a younger orthopedic surgeons, how should we be able to achieve that? Is that you identify your mentors, because there are, and there may be more than one. There may be some from your own countries. There may be some from other places. You can see that there are these different ones that. These are different mentors in my career. There are some that is when I'm junior, they teach me how to become an orthopedic surgeon, and there are some that who's making me fit into different societies. Identify your allies, because these are the ones that who have been building up with you for the time throughout your career. They will share your happiness. They will share your disappointment and sorrow and give you advice. So these are the ones that not just for work companion, but basically they'll eat and drink with you. They will share your emotions. And as a junior, especially as a minority, you have to identify your goals earlier. You have to commit and work hard. It is sometimes nowadays there's so many people who talk about diversity. They think that, oh well, they may get invited very early on to sit in a group, but you need to commit and work hard. So you should try to integrate, even though that there may be different people who look at it as, oh, we just want him or her to be there just so that it looks good. But commit and work hard and make the committee, make all the other members to change the point of view and find that you are actually a good person to be with and to be around, and you can contribute. But at the same time, don't overstretch yourself, because most of the times that there may be people that who tend to, that if you deliver, you get asked to do more and more things. So you need to know your limit and you need to delegate. And at some point, you need to become from a mentee, you need to become a mentor, and you need to inspire your juniors as well. So with that, thank you very much. I do think that SICOT is a very good platform to help anybody in Nepal, in any of the Nepal Orthopaedic Association, because we are having different kinds of opportunities for both the young surgeons as well as the senior members, because we do want to know what is being needed and how we can help for Nepal and for other countries in the world. So last but not least, I think we have reporters. Please do come and join the Kyoto Annual Congress. There's only a few more days of the Congress, and there's abstract submission. So with that, thank you very much.
Thank you, Margaret, for your excellent talk on leadership and mentorship. And I think you have given very important advices, which I think will be a good lesson to all our young surgeons. And obviously, I have been pushing also regarding that. Let's have more abstract for our SICOT World Congress. And this meeting is an excellent opportunity for fitting with the theme of our ORTHOCON this year, where we have education, innovation, and collaboration. And so this is an excellent collaboration between SICOT and Nepal Orthopaedic Association. And I'm sure in future also we will try to strengthen this as much as possible. So once again, thank you very much, and hope to see you with a nice number of delegates in Kyoto. Thank you.
Yes, thank you, Vijayendra, for basically invite us to contribute to the society. It would be great if we could have come face to face, but it was just a little bit of short notice. But we'll try our best to join for any of your other congress in the future. Yes, and thank you for all the support and yes, and the contribution.
Thank you. So I think with this we come to this meeting, and over to the host. Thank you.
Thank you.